Hello everyone, I'm talking this afternoon on diversity in sexual health consultations, and my name is Henny Williams. I'm a sexual health physician. I work at Melbourne Sexual Health Centre, and I also have an academic position at the Melbourne School of Population and Global Health, where I coordinate the graduate certificate in sexual health, and I teach the sexual health subjects in the Masters of Public Health. I wanted to first of all start by asking you to think about why sexual health consultations are different from other consultations. Now, many of the issues that we face in sexual health are similar to other sensitive areas, but the content that you may be faced with is always or generally very sensitive and personal, but there are other areas that we deal with sensitive and personal information in health. Priority groups that we see in sexual health are probably a bit different from priority groups in other specialties. The need for accessible services without judgment is really important, although the acknowledgement of professional boundaries is also very important in sexual health. It's also important that our professional and personal values and boundaries do not impact and help us or create us to form judgment about other people's whose boundaries and values may be different. Now, there's a lot written about priority groups or core groups in sexual health services, and this was just a diagram that I got from the New South Wales STI government website, which is particularly good, but it really highlights that some people may belong to more than one core group or priority group. So a young person from an Indigenous background may be particularly at risk with regards to sexual health because some of the vulnerabilities may overlap. But the priority groups are usually people under the age of 25, sex workers, Indigenous and Torres Strait Islanders, people who inject drugs, gay men and men who have sex with men, transgender individuals, people living with HIV, people who are contacted of an STI, and people with symptoms of an STI. They're people who are going to have high rates of STIs when they're seen generally. But it's just important to remember that some of the at-risk factors may overlap between different priority groups. Stigma is really important with regards to STI medicine. Stigma is a mark of disgrace which sets somebody apart from others. And services which are judgmental and not accessible for marginalised people increase stigma. And we see stigma associated with the presence of an STI. We also see stigma associated with varying sexualities, even in communities such as metropolitan Melbourne in 2020. And this can impact on health outcomes. So stigma is associated with stereotypes. It causes a division, which causes a loss of social status, discrimination and labelling, which is then reinforced by further stereotypical actions and stigma. So it's a circle which needs to be broken, and providing non-judgmental, accessible services is one way to help break down stigma in sexual health. We know that stigma is talked about a great deal with certain STIs, particularly HIV and particularly herpes. And at a conference I attended recently, an international conference, there were many sessions on stigma and HIV and how the presence of stigma around HIV can impact negatively on people's health outcomes. We know that after a diagnosis of HIV, there may be discrimination and stigma towards individuals living with HIV. And this may cause estrangement from family and friends because of other people's fear of infection. There are also fear of complications and death. There can be feelings of guilt and shame and loss of autonomy and dignity, which can feel like a burden and therefore cause depression, loneliness, isolation, and again, reduced health outcomes. So one of the most important decisions that people living with HIV after a diagnosis have to make is whether to disclose that diagnosis to other people and who to disclose it to. And we often counsel people about just being very careful who they disclose to initially. We want people to disclose and to be open with their friends and their family, but it's really important that people consider very carefully who they tell, and initially only tell one or two very trusted members of family or friends who can support them. Occasionally, it can cause more discrimination and stigma if they disclose to the wrong person. So it's something which is very important after a diagnosis of HIV. We also see a lot of stigma associated with herpes as well. And this can be difficult to deal with, and patients can need ongoing counselling around this association of stigma with herpes. The New South Wales Government STI Programme Unit has a lot of very important information there, which I would advise some of you have a look at. And it does talk about how it's important to expel myths that are associated with STIs. And some of the common myths are that people who get an STI are promiscuous. We don't like the word promiscuous, it's very subjective. The fact that married people don't get STIs, you can get STIs from toilet seats. Myths like that, which should be really demythed and debulked with individuals so they know what the facts are around STIs. The myths that sex workers have a lot of STIs, only gay men get HIV, people who get an STI are dirty, and that you can't get an STI if you only have one partner, all untrue and need to be discussed if people appear to be having those myths and mistruths. Our patients need to understand that we are giving them important factual information and we need to educate people around that. So overall, for those who may be marginalised and find access difficult in sexual health, it's really important that we can recognise individual differences, that we ensure access without judgment, that we enable and encourage attendance at clinics in order to get sexual health checkups, and we reduce barriers to access. There are differences in our population when we see people for sexual health consultations in race, ethnicity, gender, sexual orientation, socioeconomic status, age, physical ability, religious beliefs, political beliefs, and other ideologies. So we do see a very diverse population, and for some people that can be challenging in sexual health consultations. Communication is probably one of the most important aspects of inclusivity, and to try and reduce judgment and stigma associated with STIs. First impressions at reception really matter, and the staff who meet patients first will often make a lasting effect on those individuals. So it's ideal for staff to ask about a preferred name and a pronoun and ask them for their preference around that. Just simple things such as posters in the waiting room and all the practice staff demonstrating that you welcome all individuals with no judgment and that this space is safe for all of those individuals and that you can talk confidentially to a healthcare professional. Those things are very important in reducing stigma and having a welcoming practice to people who need access to sexual health services. Gender and gender diversity are something that you will come across in sexual health medicine, and it's important that we're all clear about what the definitions are. Gender identity is one's internal sense of being male or female, and everyone has a gender identity. For transgender individuals, their sex assigned at birth and their own internal sense of gender identity are not the same, they're different. And that's when they may become distressed because of that and may decide to declare themselves as transgender individuals. Gender expression is a physical manifestation of a person's gender identity through clothing, hairstyle, voice. And most transgender people aim to make their gender expression, how they look, match their gender identity of who they are, rather than their sex assigned at birth. And this can cause confusion, particularly when checking into a clinic and having personal questions asked about their age, their sex, their gender. So it's always important for staff who are at the front line to be very aware of gender diversity and very aware that they should ask patients about what gender they prefer, how they want to be referred to, what's their preferred name and what's their preferred pronoun. Cisgender is a term for someone who exclusively identifies as their sex assigned at birth. And bigender is somebody who refers to their identity as two genders, and also multigender you can have as well. When you have an intake form at reception, it is important that these are inclusive forms and that you ask sensitively around gender. There are many examples of best practice, and this is just one of them, which I've taken from a thesis that's written by an MPH student that was used in a clinic in Sydney called the Checkout Clinic. And it asks about the current gender identity, what sex you were assigned at birth, and whether you were born with a variation of sex characteristics, which is sometimes called intersex. And then you can select a pronoun that you would prefer to use in this clinic setting. Having posters in your waiting room such as this, demonstrating that you're aware of the Rainbow organisation, which is encompassing all genders and gender diverse friendly, is very important for people. It gives them a sense of empowerment, and it enables them to feel comfortable in your clinic setting, that they are safe in that area. And you can get these posters from many places. The Rainbow organisation provides some training and standards whereby you can decide that your practice, you want to work towards getting a rainbow tick to show that you're very gender friendly, and there are certain things you can move towards with the Rainbow organisation. And having a rainbow tick or having a demonstration of being aware of all these things in your practice is really a really big step when you're trying to encourage people to come to you for sexual health issues, because gender diversity and gender inclusivity is very important with regards to sexual health. So this is just some definitions that you are probably aware of, but is available here just for you to recap and make sure you're familiar with. If you refer to gender binary, you're talking about two distinct opposite sexes. Transgender is an umbrella term, as I've said, when the sex that you were born with at birth and assigned is different to the gender that you feel. Cisgender is somebody who identifies exclusively as the sex they were assigned at birth and is opposite from transgender. Genderqueer is when you don't identify with gender binary, as in two distinct binary genders. And transition is when one is changing one's gender expression to match one's gender identity. And there are terms which are correct and incorrect here. And I don't want you to feel frightened when you read this, because people are very frightened of making mistakes. And I think we all feel a bit like that. We all want to do the right thing and we're worried about doing the wrong thing. But when you're on a one-on-one consultation with an individual, it's fine for you to ask them what they prefer with regards to their pronoun and their name and things like that. And just showing that you are welcoming and not discriminatory is very important for individuals who are gender diverse. So gender pronouns, as you know, can be she, he, they, or ze, and most people will tell you what they prefer with their pronoun, and it's very important. Just the nature of asking that shows that you do respect their individual choices and will make all people from different genders welcome. There is some very good in-depth training for working in health practices around trans health, and the Northwest Primary Healthcare Service has got a very good module, which is produced by Dr. Ruth McNair, who's done a lot of academic work and healthcare work around transgender individuals. It's really worth doing. It's free of charge, and you can get it from the Northwest Primary Healthcare setting. I don't think it takes very long. It's about an hour or so, but it's a really good module if anybody's interested in improving their skills and knowledge around this area. The other thing to have a look at, if you have a more academic interest, is the survey results from trans and gender diverse health from the Kirby Institute in the University of New South Wales. And the link is there, but if you Google that on the Kirby Institute, you'll be able to find that. It has a lot of interesting background information on trans and gender diverse health. So I think in sexual health, we do find uniquely challenging situations. For example, you may see a 26-year-old bisexual man who's on PrEP, who's attended many times because of gonorrhea and other STIs, and has had syphilis in the past. It's not uncommon for bisexual men to be married and living a life with their children and a family in a heterosexual relationship, but in fact having sex with men in very risky situations, such as sex on premises venues. And this is the sort of thing that people can find very challenging. In many ways, you just want to say, you know, if you used a condom, that would reduce the issues with regards to transmitting STIs to your wife. It's very important, however, that we acknowledge that it's a great issue for these people in accessing services. They don't want to be judged. They shouldn't be judged. They should be able to get free, easy access to services that can provide them with positive health information to help keep them safe and help keep their partners safe. Very commonly, it's just too difficult for these men to come out to their wives, and therefore the most we can do is minimise harm by offering PrEP, making sure they get PrEP regularly and they don't come off PrEP, treating and diagnosing their STIs, and trying to encourage them to use condoms to protect their partners. Very often these people may want to see counsellors, and if you can facilitate that, that's great, because it may be to do with a great deal of fear and inner homophobic feelings around not wanting to come out as a bisexual man fully or as a gay man. And there's a lot of work psychologically and socially which can be done with these men often to enable them to keep themselves safe. But giving them a safe, friendly, non-judgmental environment is the most important thing that we can do. There are lots of different reasons that people have sex, and we must remember this. They may be different from our values, but people have sex for money, for intimacy, for communication reasons, for power, for love, for commitment, and we all are different. And I think it's important to remember that other people have different values to us, and that's fine, and we must remain very professional and not judge people for their different values. There are personal and professional boundaries that are important, and it's important to remember that sex is also confined by norms which are different in different people. One of the areas that a lot of people report as finding quite challenging is when you're working with women from different backgrounds, geographically and ethnically and culturally, FGM or genital cutting. This is now defined by the WHO as a human rights violation. There are no health benefits that are acknowledged, just harmful effects, and it is illegal to perform this in Australia. But we do see some women who have lived in countries where FGM is quite routine for young girls who come to Australia, and we will see them in sexual health consultations. So the WHO is a good place to start if you want to read up about FGM, but it involves a partial or total removal of the external female genitalia and other injury to the female genital organs. It's not a medical procedure. It has no health benefits for girls and women, and it can cause severe complications, acute and long-term, severe bleeding, lack of sexual enjoyment, and long-term issues. The majority of FGM these days is carried out in that strip that you can see across the top of Africa, including the Middle East and going all the way to the northwest of Africa. So if you see women who have had FGM performed, it's quite likely that they have been born and had they lived for the first couple of decades or first decade of their life in one of these countries in North Africa. It's important to acknowledge that we will see women with this. We may see them brought in by their male partner complaining of other issues, but happen to have had female genital mutilation performed. You're unlikely to see them immediately when they will present to emergency departments in those countries where that is performed, but you may see them with long-term complications. You may see them when they're pregnant. You may see them with urinary problems, vaginal problems, menstrual disorders, scar issues, sexual problems. And these issues can be difficult when women have had genital cutting. So in all states in Australia, the law prohibits the practice of FGM, and there have been Commonwealth funds to support action to end FGM way back in 2012, but it still does occur. We know that there's certain legislation in Victoria. There's a crime legislation, the Crimes Act, female genital mutilation way back from 1996, which means that it is illegal to perform FGM in Australia, but it can also be legal under the Children, Youth and Families Act of 2005. So if you see, for example, families who come from that north area of Africa where FGM is common, who are taking young girls back for periods of time over school holidays, it is important that we realise that this may be occurring because of FGM, and we need to, if it is something which we form a reasonable belief on, we need to inform children, youth and family social services. So we need to be aware that this does happen still, that families will take young girls home from Australia and other developed countries to have some form of genital cutting performed in their country of origin. And we need to try and stop this if it is happening under a legal framework that we have. So what do you do if you see a woman who you think may have had female genital cutting? It's important to ask them which country they come from, if they've ever had an examination in the genital area, if they've ever had any genital cutting. They may be aware of this, may not be aware of this. And you can explain that it's okay and you understand, and can offer to refer them to experts to help them with any complications as a result of FGM. Now, the Centre for Ethnicity and Health and the Multicultural Centre for Women's Health both have fantastic resources around FGM to help communities and individuals face the difficulties that arise as a result of that. Also at the Women's Hospital, they have a programme called the FARET programme, who will deliver education to health professionals and also to communities around FGM and what to look out for, and also what to offer women and families who are affected by FGM. So there's a lot of resources out there. It's just about where you go to get hold of them. So this is the Centre for Ethnicity and Health that do a lot of work in this area and have a lot of resources on their website, or you can often ring and speak to somebody around this. There are many cultural considerations when seeing women from this area, and they need to be considered. You need to think about their ethnicity and their country of birth, their preferred language. They may need an interpreter, their level of literacy. So it's often not helpful to give them something written in their language because they may not actually read or speak that language. So you need to establish that through an interpreter speaking the local language. Again, you need to ask them if they're happy to have an interpreter, because many of these communities may have interpreters from their own community and may not want to use them. So you need to talk about their migration status and experience, their beliefs about health and illness, which may be very different from ours, how they understand and if they need help navigating the health system, family and social support, religious practices, dietary practices. But the Centre for Ethnicity and Health will run and provide many resources in this area. So they're definitely a place to go to get some help. So just think about these issues that you may be faced with in sexual health consultations with women and men from ethnically diverse backgrounds. FGM, if they're from a particular area, you may want to have brochures, information in different languages. You will want to have interpreting services available. You will want to consider privacy and confidentiality, particularly for young people, because confidentiality and privacy is very different in certain ethnic groups. You'll want to think about cultural competency training for your health professionals, and you need to be open and welcoming to all groups. So within sexual health, we need to think about treating everyone the same as we do in all health consultations. Adolescents, there are specific areas around adolescence you need to be aware of, and I've discussed this in my other talk on young people in sexual health. So talking about confidentiality and the law around that. You need to think about gender diversity as well as cultural diversity, and you need to think about intake forms and general attitudes and posters which are should be displayed in the reception area and the area that people come in initially to, and also the staff that they talk about with initially around their intake, so their basic demographic details. That first impression is very important for people when they're accessing a service and they're very worried and anxious about that service. I had a talk to some of our very experienced staff here at Melbourne Sexual Health Centre in reception to ask them about what were the most important things they had learned about diversity and being welcoming to people from all different areas coming in for sexual health services. And these were the answers that I got, which I thought were really interesting. So one person mentioned the Northwest Primary Healthcare Network transgender training, which I've given you the link to, and how useful that she found that with regards to being aware of issues around gender diversity. Another person talked about the signage, and that we know that LGBT people don't always feel safe disclosing information about their sexual health because they're worried about discrimination. And they've acknowledged that seeing a rainbow flag at the front door in the waiting room can have a significant effect and really help those people who feel anxious about disclosing. Aboriginal health inclusivity, so encouraging STI screening in any Aboriginal person attending for practice, noting whether they have an Aboriginal background or a Torres Strait Islander background, and identifying and recording that identification on an intake form is very important, and acknowledging it. One of the admin staff that said, I think the most important lesson I've learned here is to never assume someone's gender preference from their appearance, and always to ask, What gender do you identify with, or what pronouns do you prefer? That's really important. It seems really basic, but it is something we can forget, and it's something that new staff coming in might not be aware of. So another staff member in administration and reception said a lot of people are very anxious about coming here and embarrassed about what they're going to be asked to talk about. If I notice this, I help them out with registration and reassure them that all the doctors and nurses are really nice here. If anyone is very young, extremely anxious or upset, I always ring through to the triage nurse to ask them for them to be seen as soon as possible. So that's really good. That's something that reception can do to help reduce anxiety in people attending for the service. Friendly reception staff are the key to helping people feel comfortable and welcome, and not just walking straight out because they feel absolutely terrified when they turn up at the service. And that's what a senior nurse in our service said. So one of the top tips that somebody else gave was having an inclusive intake form and being careful about inclusive and respectful language. So not making people feel excluded as soon as they see that form or have some questions asked of them by reception staff. So those are really important things that our staff think are crucial when providing a non-judgmental service. The resources that I want you to be available of are the youth-friendly resources that I've talked about in my previous talk. Gender diversity, as Thorn Harbour provide a very good resource for that. There's good sex worker teaching and resources that we've made available to practices, and that's very important with regards to being open and non-discriminatory. There's culturally and linguistically diverse resources at both of those websites. There are resources around disability and sexual and reproductive health, and there's some training coming out which is going to be available soon for health professionals training in sexual and reproductive health and disability through some government funding. It's not there yet, but watch this space, and that's a website that you may find it at. And Family Planning Victoria have an interest in disability and sexual reproductive health, so they're always good people to contact around that. Thank you very much.